people have realized the importance of laboratory medicine in this COVID time. Everybody is under confusion whether to test or not to test, if to test, what test to be done, whether it is some antigen testing or antibody testing, or if it is antigen testing, whether it is through RT-PCR or CVNet or TrueNet, what are the limitations of a particular test, what are the advantages of a particular test. In a nutshell, everybody has realized the importance of this laboratory medicine. And also, if we have to test, how we can improve quality without increasing cost. Today, we will discuss these aspects of laboratory medicine. So for this, we have one very good way with this 6 sigma matrices. With this 6 sigma, we can improve quality, and with this lean concept, we can reduce our cost. All of you will agree with me, our 70% clinical decisions are based on reports generated by laboratory. And as a laboratory person, we want to release error-free report, which is meaningful for clinician. They can make a correct diagnosis so that patient is receiving correct treatment. And ultimately, as laboratory people, we are helping our clinicians in better patient care. For this, we have to understand certain terminologies, which we use in our day-to-day practice. Everybody uses this terminology, quality assurance. What is quality assurance? We are telling our users, in our laboratory, we will take care of all quality requirements. Then we have to understand what exactly we are doing in our laboratory. We have to develop a system in our laboratory of quality control. Not only examination. You must have seen many times people say our laboratory is good laboratory. Why? Because we have very good equipments. This equipment is available all across the country, only in our laboratory. But remember, 80 to 85% errors are occurring in the pre-examination phase, and quality of our result is only as good as the quality of specimen received. So we have to ensure quality control at all levels: pre-examination, examination, and post-examination. For that, what is required? A good quality management system. Good quality management system is, it is well documented based on some international criteria. It is well implemented and well monitored. Now thing is how we can monitor and what is the advantage of this. We need some powerful tool, so that if suppose we want to see what is the quality of this particular method to perform a particular test. If suppose we have options for 3-4 instruments, what is the best instrument for our laboratory? How we can compare instruments? Or if we already have one existing equipment, how we can harmonize other instrument with this instrument? Or if suppose we have to optimize our QC procedures. Every time people ask how many controls to be run, how frequently these shall be run, and what all rules shall be applied. So with this, we shall have some technology. With this, we can control all these things. And also, we can have a check on our process variation. We say in our IQC, we hardly get any outlier. In case of aqua, sometimes we get outliers. Clinicians and patients who are our users, they are not concerned about all these things. Whether you are getting any outlier in aquas or not, whether all aquas results are okay or not, they want to know what is the reliability of a particular test in the laboratory. Sometimes people complain, we are getting a lot of problems from the laboratory. A lot of typing error is there in the post-examination phase, or a lot of samples are getting hemolyzed in the pre-examination phase, or a lot of significant number of venipuncture failure is there. How we can quantify all these things so that we can have better control over our lab performance. When we try to evaluate, some people say previously it was not good, but now we have improved a lot. And they are saying, no, previously it was okay, but now it is worse than before. A lot of subjectivity in the statements. How we can develop objectivity in it through this Six Sigma concept. What is sigma? Sigma is a symbol for standard deviation. And if we follow Six Sigma, it was first started with Motorola, and then General Motors, General Electric also accepted that. They say if some quality is at the level of 6 sigma, then out of 1 million possibility, there is error possibility is only 3.4. And this is very less, and this is, they say, world class quality. In this, what we do, we count errors and converted those errors into defects per million opportunity. These errors are called defects. Suppose there are 36 errors in 10,000. Then these are converted, 10,000 converted million, and 36 is also multiplied by the same multiplication factor. And with some chart, this is converted into sigma matrix. Then we come to know what is the present status of a particular activity. Before proceeding further, we should have an idea. Suppose we are working at 6 sigma level. That means there is possibility of only 3.4 errors out of 1 million possibility. If we are working at 5 sigma, then there is possibility of 233 errors out of 1 million. And same is true for your 4 sigma, 3 sigma, 2 sigma, and 1 sigma. With this 1 sigma, 6,91,462 out of 1 million possibility. These figures we have to keep in mind before proceeding further. And also in the interpretation of the six sigma, we will be requiring some tools. These statistical formulas are called statistical tools. We should understand what is bias percentage and what is imprecision. Bias is a matter of, bias is a tool for checking accuracy. How close our result is to true value. When we participate in EQUAS in our laboratory, target value provided to us by that EQUAS provider is generally group mean. And because this term is used in many industries, and except this medical laboratory, in all places where they are performing this metrology, metrology means study of measurement. Wherever they are using this metrology, medical laboratory is the only example where we are working with a single test result. Otherwise, they perform tests multiple times and then they take group mean. Here, correct term is group mean, but in our medical laboratory, we follow this group mean for all the participants, and they use lab mean, but in our laboratory, we use lab result. This is bias percentage, measure of accuracy, and CV percent is a measure of imprecision. Bias we get from the EQUAS report, and CV percent we get from our internal quality control. For this imprecision, we divide standard deviation by mean into 100, and for bias percentage, we subtract group mean from the lab result, and it is divided by group mean into 100. Now we are getting one value from the EQUAS report and one value from the IQC report. With this bias, we are getting accuracy, and with this IQC report, we are getting imprecision. Now we are proceeding further. This is we will be using in our process variation. For process outcome, we calculate number of defects. Then these are converted into defects per million opportunity, as we discussed earlier, and then these are converted into sigma matrix. Now see, this term is total error allowable. This term, this value we get from our literature. Like there is one guidelines by Kerman Ricos, another guidelines by Riley Bank. We can use any of these, and there are some other guidelines also. From that literature, we get this total error allowable. This is different from total analytical error. This is TEA, A small, total error allowable. This we get from the literature. There is another term that is called total error, TE, or total analytical error, that we calculate in our laboratory, that we will see afterwards. To calculate this 6 sigma, we subtract bias from the total error allowable, and this is divided by CV%. With this, we get sigma value for that analyte, which is including imprecision as well as bias. Otherwise, in our equas, we are taking care of only accuracy, and in our IQC, we are taking care of only our imprecision. Here, we are integrating both. So this is good way of checking a particular analyte or checking a quality of a particular analyte. And internationally, what they say, although it may sound little absurd, the minimum acceptable performance is 3 sigma and world-class performance is 6 sigma. Whatever sigma level we are getting initially, we shall work hard to improve that sigma level towards 6 sigma. Now, if we see this formula, total error allowable minus bias divided by CV. In addition to this, we have to see this quality goal index. This is bias divided by 1.5 multiplied by CV. If suppose this quality goal index is less than 0.8, that means CV is high. There is imprecision. If it is more than 1.2, that means bias is high. It is inaccuracy. If it is between 0.8 to 1.2, then that means there is imprecision as well as inaccuracy. You may say, if there is no other possibility, it will be either less than 0.8 or 0.8 to 1.2 or more than 1.2. So that means in every case there is imprecision and inaccuracy. But we use this quality goal index only when our performance is less than minimum acceptable performance. When our standard this sigma level is less than 3, then we use this quality goal index to see whether there is imprecision or there is inaccuracy or both. And if we plot a chart like this, on this x-axis we are keeping this imprecision, and on y-axis we are keeping this bias. What is our tendency? Both imprecision and bias should be as minimum as possible. So this should be this should be near the start of this vertical and horizontal line. That means should be as close to 0 as possible. That means we are working at the 6 sigma level for those analytes. But if it is beyond that dotted line, that means our quality is bad, and we have to think seriously what is required in our laboratory, why we are getting so much inaccuracy and imprecision. And see, this data we collected in 2019, CV% for these 10 analytes over a period of 6 months. Then we calculated average for the 6 months. What is our average CV% for these 10 analytes? So with that, we got information about imprecision. Then we calculated bias from our equas data, and then we calculated this bias percentage for every month, and then we calculated average bias percentage for the 6 months. Now we have bias percentage as well as CV%. That means information about inaccuracy and information about our imprecision. Now we are proceeding further. So now we are using this. We have total error allowable from reference. We have bias percentage from our EQUAS, CV% from our IQC. Now we have calculated sigma score for different analytes. So then we realized for this creatinine, glucose, total protein, this sigma value is less than 3. And we also calculated quality goal index. As we discussed earlier, how this quality goal index is calculated, bias divided by 1.5 into CV. So now we have this information. This we are discussing process variation, our different analytes. And this is the very important aspect of our laboratory, whether the report which we are releasing from our laboratory is meaningful for a clinician or not. So now we have collected data, we have to analyze this data. For certain parameter, our quality is above 6 sigma, we don't require anything. For certain parameter, our quality is 5.9 to 3.0, and where it is close to 3, we may think why we are getting such a low sigma value, and cases where this value is less than 3 sigma, definitely we have to think seriously about those analytes. What is the reason? If there is inaccuracy, what is the reason? If there is imprecision, what is the reason? We have to do root cause analysis and we have to take appropriate action. So now when we are analyzing, as we discussed, those analytes, and we took some other examples also in this, we were not included in the study. This 6 sigma, where values were less than 3, based on quality goal index, whether there is imprecision or there is inaccuracy or both, inaccuracy as well as imprecision. As we discussed, if it is between 0.8 to 1.2, there is inaccuracy as well as imprecision. So based on this, what is our sigma matrix level? We have to decide how many controls we will use in our laboratory and how many Westgard rules we will follow, and what should be the frequency of these controls. How frequently? Lower the sigma level, more controls need to run. Higher the sigma level, less control need to run. So with this, we can reduce our cost and our quality will also improve. With this, we have checked our process variation related to different analytes, but also we have to see process outcome, labeling errors, or in histopathology, quantity of the formalin is not adequate with the specimen, or clinical history is not available. Anything we can select, we have to see defects per million opportunity. For examination, we can keep as a number of plotted EDTA sample, which we didn't recognize initially. And after running, when we are getting low platelets, some other parameters, then we are checking this was plotted sample, these type of issues, or IQC or EQUAS errors that we are keeping as process outcome, or post-analytical errors, typing mistake. If suppose we are typing 5 things in 200 reports, name, age, gender, referring doctor name, test name, and result, and suppose we are typing 200 reports. In every report, there is possibility of 6 errors. So that means in 200 reports, total error possibility is 1200. We have to see out of 1200, how many errors are there. Then we can convert this into defect per million opportunity, and we can get sigma score, and we can compare this sigma score over a period of time. What is required? We need to change our habits. Sometimes we feel very happy when we are talking about quality. Sometimes we say oh, I am running laboratory for last 30 years, or I'm running laboratory for last 5 years, or my laboratory is 50-year-old. Nobody can challenge our quality. We are maintaining very good quality. But what is the reference? What is the standard you are using? No, but we are maintaining very good quality and we are comfortable with that. Nobody should question our quality. But whatever we are saying, our statement shall have some objectivity. So that we don't have to say anything. Quality itself is speaking. And when we will start following this Six Sigma matrix, definitely when this Six Sigma matrix is increasing, our productivity is increasing, acceptability by consumer is increasing, and definitely our reputation is also increasing. We can reduce our cost because there is less redos and repeats. Less inventory we need to maintain, and when there are less redos and repeat, our turnaround time will also improve. That means it is decreased, and we need less analytical time to perform a particular test. That means overall laboratory will gain more reputation and more happiness. To see this process outcome, we collected data for the same period. In this time, we collected 562 specimens, 6 hemolyzed samples, 7 venipuncture failure, this 9 clotted EDTA blood. The total errors were 22. We analyzed these 3 aspects. The total errors were 22. So when this data was converted into sigma value, first in defect per million opportunity, and then sigma value for this total number of errors, our sigma value was 4.5, hemolyzed 4.9, then 4.8, 4.7 for clotted blood. So then we analyzed this data, and we thought there are certain reasons for this low sigma value. Improper training to our people, and sometimes they are not mixing sample properly because of this improper training, and they are not, or sometimes they are mixing very vigorously. That is why samples are getting hemolyzed, and storage is also not proper. So we thought we will conduct training and post-training evaluation also, whether they have understood the concept of training or not. In this training, we will teach them what is the correct procedure of mixing and how this sample shall be stored. So we performed all these activities, regular training and competence assessment. What is competence? Ability to use acquired knowledge and skill in practical situation. One thing is training. You have conducted post-training evaluation also. You have to see whether a person is able to carry out that activity in practical situation or not. Proper environmental monitoring, and we thought we will work hard so that we will be able to achieve 6 sigma level above 5 in the pre-analytical phase, and when after 6 months we have evaluated, we were able to get 6 sigma more than 5. What is required in this 6 sigma? First, you have to identify the problem. First, we have to accept there is problem. What is the problem? Then you are collecting data related to that problem. You are measuring how much problem you are observing. Suppose you are finding there is a problem in the labeling. Then you have to see how many samples you are receiving with incorrect labeling or unlabeled sample. Then you are converting that to statistical terms, like if you are following 6 sigma, the 6 sigma score, and then you are finding out, okay, how I can improve this activity. And when whatever measures you are taking, you see whatever measures you are taking, people are implementing those measures in a correct way, and these measures are in a non-reversible direction. That means towards improvement side. It is not like that after few months when you started monitoring that, Again, it is going back to that old situation. We have to see that. So with this Six Sigma, we can apply to different aspects, whether these aspects are related to process outcome, process variation, and we can improve quality in our laboratory. These are the different activities in our laboratory which can increase burden on us, either incorrect data entry or suppose 100 tests we are releasing daily, and on this our people who are typing, they are wasting 50 extra sheets or 60 extra sheets. So if we can control that, we will save money, we will save time also, and we can reduce the possibility of releasing an erroneous report. Same is true for your transportation. You can reduce the number of steps, and distance is also a limiting factor. If suppose lot of waiting is there at the reception, you have to take care, or about sample registration or report collection. Inventory also you have to maintain. So for all these activities, what we can do, we can use this Six Sigma. And now we have understood Six Sigma helps us with cost saving and better resource management. And we can define appropriate QC strategy for our laboratory. For that, there is one CLSI document also, evaluation protocol, EP23A. So you can refer to that also. And if we are following appropriate QC strategy, we can reduce number of controls, we can reduce frequency of control, and we can also optimize our Westguard tools. Thank you very much.
Thank you so much, sir. Since we are on the scarcity of time, so I will now move to the next speaker, with your permission. And we can, and just to inform everybody who is attending, sir's MELAP, the MELAP course material that sirs have generally, we have sir has sessions. It's very informative. I was privileged to attend one of them. So I will encourage you to check out the MELAP different courses that sir comes up with, and they are very, very informative. So with that, thank you, sir.